Good morning, everybody. I am Netravati Bomanalli from second year MBBS. Today, I am going to do a seminar on rheumatoid arthritis, a chronic multisystem autoimmune disease. Rheumatoid arthritis is a chronic multisystem disease of unknown cause. Though the most prominent manifestation of rheumatoid arthritis is inflammatory arthritis of peripheral joint, usually with a symmetrical distribution, its systemic manifestations include hematologic, pulmonary, neurological, and cardiovascular abnormalities. Let's move on to the disease definition. Rheumatoid arthritis is a chronic autoimmune inflammatory condition that primarily affects synovial joints. The features are as follows: chronic multisystem involvement, symmetrical polyarthritis, extra-articular systemic manifestations, progressive joint destruction. Rheumatoid arthritis is a common disease having a peak incidence of in third to fourth decades of life, with a 3 to 5 times higher preponderances in females. The condition has a high association with HL and DR4, HLA and DR1, and has a familial aggregations. Pathogenesis, I am representing it as a flowchart. The disease initiates with a genetic susceptibility and environmental triggers such as smoking, infections, leading to synovial inflammation. Pro-inflammatory cytokines like TNF alpha and IL-1 drive cartilage and bone erosion. Let's see the flowchart of rheumatoid arthritis pathogenesis. Here, genetics, that is HLA-DRB1 and ST84, environmental triggers such as infections, smoking, sex hormones. When these are affected, macrophages and dendritic cells are thought to present, investigating antigens to T cells, causing T cell activation and proliferation. Activated T cells produces inflammatory cytokines, stimulate B cell inflammation and differentiation into plasma cells. The inflammatory response is systemic. This reduces the production of hyaluron, major lubricant in synovial fluid. Inflammation increases matrix metalloproteins production and increase cartilage damage. Plasma cells antibodies form immune complexes indirectly damages the cartilage. Joint damage recruits neutrophils, T cells, beta cells into joint space, causing hyperplasia and angiogenesis of the synovial membrane. Neovascularized hyperplastic synovium invades and enzymatically destroys joint tissue. Untreated severe rheumatoid arthritis will affect the entire body. Histological features are villus hypertrophy, enlarged synovial villi will be present in this, pannus formation, aggregation, aggressive synovial proliferation, rheumatoid follicles, chronic inflammatory cell infiltration will be present, fibrin deposition, superficial layering on synovium. Genetic factors. Genetic influence is a significant in the initiation of rheumatoid arthritis. Susceptibility is directly linked to HLA-DR4, major histocompatibility complex association, shared epitope, structural domain conferring risk, familial aggregation suggests complex polygenic traits. Antigen plus HLA-DR4 is equal to the immune activation. Articular lesions. Rheumatoid arthritis typically affects small joint symmetrically. Proximal interphalangeal and metacarpophalangeal joints, synovitis leading to swelling, redness, and warm joints. Pannus inverts bone cartilage causing irreversible damage. Cervical spine involvement is common. Lumbar spine usually spared. Clinical presentation: morning stiffness lasting for 1 hour, relieved by movement. Symmetrical joint pain affects small joints of hands and feet. Then systemic symptoms such as fatigue, weight loss, low grade fever, deformity such as ulnar deviation, potaneer, and swan neck. Continuing with clinical deformities, progressive progression of rheumatoid arthritis leads to joint destruction, ulnar deviation of fingers, that is outward deviation, swan neck and botania deformities, joint subluxation and instability. Rheumatoid nodules, a classic extra-articular manifestation, firm subcutaneous bumps near pressure points, example elbows, knee joints, central necrotic zone surrounded by palisading macrophages, plasma cells, can also occur in the lungs or a pericardium. Extraarticular manifestations, vasculitis, small vessel inflammation, pulmonary interstitial lung disease or pleuritis, ocular, dry eyes, cardiac inflammation of pericardium or vessels, hematological, normochromic anemia. Laboratory investigation of rheumatoid arthritis are RF factor positive in 80% of cases, anti-CCP high specificity of rheumatoid arthritis, ES or a CRP elevated inflammatory markers, synovial fluid high neutrophil leukocytosis. Variant forms of rheumatoid arthritis. There are many forms in rheumatoid arthritis such as juvenile Felty syndrome and rheumatoid spondylitis. Juvenile rheumatoid arthritis is acute onset in patients which are who are less than 16 years. Felty syndrome is triad of rheumatoid arthritis, splenomegaly, and neutropenia. Rheumatoid spondylitis is involvement of spine, occipito-atlantoaxial. Then suppurative arthritis, it is a distinct form of autoimmune uh, rheumatoid arthritis. This is an acute infectious condition. Direct infection of joint by bacteria usually arrives via hematogenous route. Rapid joint destruction if not treated urgently. Suppurative arthritis is also a form of rheumatoid arthritis. Management and overview. Early diagnosis is crucial for disease modification. DMRDs slow disease progression. Biological agents such as target TNF alpha and beta cells. Rehabilitation maintain joint function and mobility. I have added some questions.